I'd like to ask Dr. Jerath to also put herself back on camera if she would. There she is. And there you are. We have so many questions that I know, Dr. Cannon, I did give you some preliminary questions. I don't know if you want to look at any of those, or whether you would rather that I ask you some that have come in since you've been talking, since they pertain to your presentation.
So I can do either. So we are now sharing the cameras and not the slides. Is that correct? Fine, you can stay there.
Yeah, I'm looking. Yeah, I've also got the cameras up on my screen, so okay. I can't share my screen and your screen at the same time.
Okay. That's fine. I will. This first slide is about the permanent muscle weakness, and it's from Deborah, and that it happens even without episodic attacks. And we went into that, and that really the opportunity is gene therapy. So we touched on that. Another question, and this came up at the meeting in Scottsdale a couple of years ago, that many of you have heard about stem cell therapies or platelet-rich plasma or bone marrow aspirates for helping in many disorders where we're struggling for therapeutic options. And while I'm want to be open-minded about everything, as we heard back then from the experts, these therapies are certainly not going to replace muscle cells. So if you're in the status of permanent muscle weakness and loss of muscle replacement by fat, this approach is not going to replace your muscle cells. Do not be confused about that. There are other disorders in which these therapies have worked when some of the challenge is inflammation, especially autoimmunity conditions. And while I want to be open-minded again, there is no evidence that inflammation has anything to do with periodic paralysis. So from first scientific principles, I have no enthusiasm for platelet-rich plasma, bone marrow transplants, or stem cell therapies right now with where the technology is for periodic paralysis. And I just want to save you aggravation and a lot of money that I don't think that's an opportunity. And I'll let Dr. Jerath speak because I'm sure you face this in your practice.
I 100% agree with you, Dr. Cannon, on your stance on that. So none of those treatments make any sense scientifically. So.
Well, Dr. Jerath, I actually have a question that someone specifically asked me to ask you, but maybe Dr. Cannon can chime in too. They wanted to know, they said, Dr. Jerath, when you come back on again, perhaps we could do an informal poll about how many people meet the established diagnostic criteria. We could ask the following and have people virtually raise their hands to get an account. How many of you in the audience have a suspected or confirmed diagnosis of periodic paralysis? Please hit the hand button on the right-hand side of the screen to raise your hand if you do. And they go on, but they were wondering, just because we have so many people together with us right now, is there a way that we could do anything like that?
You know, I'm new to this whole conference association, so that's something that I would probably want to discuss maybe offline with Dr. Cannon and with other leaders in the field. I think there's probably quite a few out there that have their opinions. That's something that I think for other diseases such as, ALS and other neuromuscular conditions, they've had committees come together to form diagnostic criteria, and it takes many minds to get those questions answered and those diagnostic criteria streamlined so everyone's in agreement. So that may be something that we need to do nationally and internationally. And had that as a scientific committee, maybe we need to establish something like that. And for patients that are borderline. It's hard because you know, what we're learning is that there are genes that we don't know about and what they do. So those are hard cases, but I think that we should still come together and establish some newer diagnostic criteria. That's my suspicion. From all the patients I've encountered all over the country. I don't know what you think about that, Dr. Cannon. If you have any thoughts.
Yeah, so I would agree, and you've raised the really important point that there's a spectrum of sort of level of confidence of any diagnosis in medicine. And very true for periodic paralysis. And I want to make, you've made this point, but I want to make sure all the patients explicitly and viewers out there that physicians, we often focus on has there been genetic confirmation and so forth. And that's not to make any kind of judgment about the level of enthusiasm or attention to helping you, but it's really important that as we sift through the differences of people and what helps and what hasn't helped, that we don't mix apples and oranges, and that we be as accurate as we can in forming uniform groups and systematically understanding natural history and what helps. And so that's why there tends to be the focus on, you know, is there a genetic basis? And I've had the good fortune to be able to speak with some of the leaders around the world who've done the genetic screening. Our lab has never done that. We do the functional studies. And my understanding is that with very well clinically documented cases, and in addition to all the points that Dr. Jerath mentioned about at the bedside and the history, which is of course where to start, but with Bertrand Fontaine's contribution from Paris, this CMAP exercise test and Dr. McManus before him is really terrific because it's an objective clinical neurophysiology test that really is convincing for physicians that there is underlying periodic paralysis. And in some of those cases, maybe up to 20%, we just cannot find the genetic basis still. So everybody needs to be open-minded that there is bona fide organic periodic paralysis without a genetic understanding. It's there, and we need to respond accordingly.
Yeah, I absolutely agree. And I think that I have quite a few patients with variants of uncertain significance, and then some of them have gone to your lab and have also discovered more variants. And so I think maybe we can always collaborate to help these patients, because it's hard to make sense of variants. You have to do a lot of groundwork to make sure that they're actually disease causing. You have to, confirm them scientifically. And so there is that genetic component, but there's also the clinical component. And sometimes it's hard when patients don't have the genetic confirmation. So I sometimes rely on that clinical component. And I think at some point, with that normal bulimic periodic paralysis concept that a lot of physicians don't really understand, I think that we may want to develop guidelines for that at some point as a scientific community.
Yeah, I'm so glad you brought that up, because people who are not physicians who are not familiar with periodic paralysis, they have the opportunity to draw a blood sample while someone is symptomatic. If the potassium is normal, they think they've excluded the diagnosis, and that is a huge mistake. Huge mistake. So.
Let's see. I have one here from Sarah, and she says that we've been told that pain is not associated with any of the PPs. Now, this is why my doctors won't give me a diagnosis. It seems many others are in my situation. Could you explain why and how pain is associated so that she can take things further with her doctor?
I see pain in a lot of my periodic paralysis patients, and a lot of it's because the patients also have myotonia and muscle contraction, so that really does cause them to have pain, and they have pain in almost all their muscles. The problem is, again, it's hard for physicians who don't understand the disease, that it's a channelopathy, and there's a lot of overlap between some of them, that they also have pain. So it's just a problem with concepts and understanding the disease, and it's also very rare. And then the other thing I think I discussed in my talk was that pain can be excruciating, and I have patients say they don't want to live their life like that, and we have to work very hard to treat that pain. So it's just not only just a lack of knowledge on the physician's part, but it's also the extreme pain that's very hard for physicians to understand. And so I feel bad for this patient, but that's why we have these conferences, that's why we come together, and they just absolutely need to find a physician that will support them. And then again, write a letter. That's what I said earlier today, is have a letter that outlines how they'd like to manage that pain, and a physician who would support that.
Thank you. Let's see, Dr. Cannon, bumetanide seems to be effective as a warm down, but you didn't show them against each other. Obviously, it's better not to take medication. Is that correct?
Great question. It's understandable that any individual would want to minimize the amount of medication required to take. And if someone has intermittent episodes that might come once a month, to take something every day for an episode that once a month, the trade-off just might not be worth it. And so you've heard this morning, Dr. Jerath mentioned this, there's abortive therapy for an ongoing attack versus prophylactic therapy to take all the time. So we're working towards either, because there are some individuals who have, at least weekly, if not daily episodes, and would greatly benefit from prophylactic management. And we're looking at both of those. We're also working very hard on the basis for these lifestyle changes that influence susceptibility of triggering an attack, because, people like to be in control of their destiny and can use those approaches, and there's a lot of scientific basis for that. Either one of those that I showed, the warm down or the bumetanide, could work. There was a question written in about bumetanide, and if you give me just 30 seconds or so, I think I should address that. When people see this data, you might be tempted to say, why aren't I taking bumetanide right now? Why isn't my doctor prescribing it? And every time I present this and share with neuromuscular specialists, we need to be a little bit cautious. While I have no doubt about the science behind it, this is a potent diuretic that will cause potassium loss into the urine. So there's a theoretical concern that you're going to make the situation worse in the body by lowering the potassium. I will say that by preventing an attack, you're also preventing potassium from moving into the muscle compartment, which is what happens in an attack of hypo-PP. So your total body potassium isn't low, it's just in the wrong place. It's inside the muscle. And so by preventing that shift with bumetanide, even though you're losing a little bit in the urine, the trade-off might be okay. What about more practical aspects? So Doreen Fiallo in Mike Hanna's group in London, based on our animal work, actually did a placebo trial of the CMAP exercise test with bumetanide in 10 individuals. And what they found, that there was not clear evidence. Now, a CMAP test is not the same as, an attack of periodic paralysis necessarily. So what was curious, they tested about 10 patients. They couldn't show necessarily that recovery of the CMAP amplitude was different. For a positive control, you had to have an attack. So they were looking at recovery, not protection from an attack. That's one thing. Another curious thing is, of these 10 patients, 2 of them were in a low-grade spontaneous attack. And while their CMAP didn't improve, their general strength improved. So, there might be something there. And so what I'm asking patients and physicians to do is just hold off, because we're continuing to study this, and it needs to be done in a crossover trial controlled way, because it would be a shame for anybody to get overly exuberant and enthusiastic about this and take too much and get into trouble, and thereby think this is a bad choice and we could miss an opportunity. So the other thing is that the study in London, they used a 2 milligram dose, which is a pretty hefty dose of bumetanide, and it was very clear that no hypo-PP patient had an adverse event because of that. It did not induce weakness. So I remain open-minded, but there's still work to be done for the hypo-PP.
Okay, that's interesting. Tammy has a question. She says, I need a lot of salt because she sweats so much and because she's so cold all the time. If she lowers her salt, she gets dehydrated. So she needs salt and fluids. Otherwise, she has an attack.
We're assuming hypo-PP, that's the more common, or?
I think so, yeah. I kind of know Tammy, so I think so, yes.
So perspiring is one of the common ways of losing salt. That and the urine and vomiting are some of the most common ones. And you can certainly become salt depleted from that matter. And if you try to rehydrate yourself with water only, you can get into trouble, well recognized. And as people with hypo-PP know, you have to be really careful about these sport drinks because a lot of them contain a lot of sugar, which is going to get you in trouble because that's going to promote the movement of potassium into cells. So the low salt and hydration, while it does have an effect on this co-transporter, the NKCC co-transporter that I mentioned, and in the dish, we can certainly use that as an example of potential protection. That's one piece of a very complex scenario. And as much as I'm a hardcore scientist and love the data, I would never argue with patient experiences. And if somebody finds that personally replacing, in particular, sodium is beneficial for them, go with your experience. And this is the importance of self-observation and diaries. And I'll let Dr. Jerath weigh in also.
Yeah, I absolutely agree, Dr. Cannon. I am very much on board with patients doing whatever's in their best interest. And so in this situation, it seems that if she's apparently having issues, right, with sodium intake, right, and being dehydrated. But the one question I don't understand is that when she does have sodium, that she gets an attack. Is that her concern?
No, I think it's if she doesn't take the sodium, she gets an attack.
Oh, that's interesting. So that's like, Dr. Cannon, I mean, that's exactly fine if it's helping her.
Okay.
We discussed that earlier in my talk. There's some things that make patients better for some. Like pregnancy, it's better for some patients. Improves some patients' symptoms, and it doesn't improve others. So there's not really a standard rule here. And I think that the more we get feedback from patients, the more we learn about the disease.
Okay, thank you. Lois asks, I remember that in the past, insulin was used as a test for PP. Many of her episodes seem to be triggered by low blood sugar trigger, especially when she's in the hospital situations where she can't control her diet. Can you explain chemically how this becomes a trigger? We do have a lot of diabetics too.
Yeah. So I'll start, and Dr. Jerath, you can chime in as well. So the comment is absolutely accurate. Early, like in the 60s and 70s, 1960s and 70s, insulin and glucose challenge was used as a provocative test under controlled conditions in the hospital to confirm a diagnosis. Now that we have the CMAP exercise, better understanding in genetics, it would be unethical to do those. So those are no longer performed. I will say in the mice, we've done insulin and glucose challenge, and we trigger attacks of paralysis in the mice as well. But what happens is for all of us, when you take in sugars and carbohydrates, your pancreas releases insulin. This is part of the normal control of your body using that fuel and having it absorbed in the appropriate places. But part of that absorption, especially in the muscle and liver of your body, the net result of that causes a shift of potassium into muscle. So you cause a redistribution of the potassium into muscle anytime you have a glucose and insulin challenge. And if you have hypo-PP, as you've seen, that's now going to become a trigger for the depolarization and attack of weakness. So what's a normal response that your body, you've evolved to do to help you store carbohydrate and convert it to glycogen and have an energy source, gets you in trouble if you're at risk. So the things to do are not overshoot on your insulin or your glucose. If it's dietary, think about eating fats and protein before, so that you don't have such a high spike of glucose and therefore insulin. It's a very popular thing in diet, and dietitians have looked at the so-called glycemic index, which even for amount of carbohydrate and sugar in food items, there's the fraction and how fast it gets absorbed into a blood. So if you eat low glycemic index foods, that's going to be better for you. And just be mindful of an insulin dose if you have to take insulin.
Now that's a complete answer.
Okay.
Nothing more to add. Thank you.
Okay. Let's see. We have a question from Michael. It's interesting. Dr. Cannon, is there a way for patients who have an unknown genetic variant to submit a sample to someone who can help determine which one they may actually have?
Yeah. So great question. And to give you a sense of this, and I've spoken to some members of the Periodic Paralysis Association on this issue, it requires, even for someone who's experienced in this area, it requires 2 or 3 months of dedicated work by one person full time to functionally test one of these mutations. And as I think Todd Bell mentioned, and it was mentioned in the Strongbridge presentation as well, there are different levels of evidence of establishing that a variant is mutation causing. So one is what I mentioned, to make the mutation in the lab and study it. That takes 3 months, low throughput, one at a time. The other is by seeing how this variant segregates in a family. So if you have a family with multiple affected individuals, and this variant co-segregates only with the affected people and not the unaffected, that's increased evidence. And what we know very clearly is that the very same mutation, there can be hotspots, might have occurred spontaneously in a completely unrelated family. And if they have the same change and inherits in a similar pattern, then you're really getting strength of evidence. So just like the diagnosis is a spectrum, the confidence of the genetic assignment of pathogenic versus benign is on a spectrum. And in our lab, I'll share with you that from stories I hear at the PPA meeting, I'm intrigued by cases where it's clearly strongly inherited in this family. And yet it's a variant that hasn't been studied yet, or there's something unusual about a trigger. And we want to understand the science of the trigger and this particular mutation. We will go out and study that. And we're doing that right now. I wish I could say we could provide a service, but it's just not feasible. There are hundreds of variants out there of unknown significance. And the last thing I'll say, and I don't mean to manipulate the answer time, but technically, it's much easier to study in the laboratory the consequence of a mutation of the sodium channel or the chloride channel than it is for the calcium channel, or even worse, the ryanodine receptor, RYR1. So it's not equally challenging to do the functional tests in the laboratory, and that's why there's a difference in the level of certainty and the rate of screening through these different mutations.
That's excellent. I just wanted to add to that because our clinic runs heavily on interpreting variants. We do a lot of genetic testing in patients and spend a lot of time testing family members and investigating whether a variant is actually disease causing. And I've been blessed to have that experience when I was in Iowa, just to learn about, whether variants should be disease causing or not. It's very tricky. Sometimes it's impressive, Dr. Cannon, it takes you a few months. For many people, it takes years. It takes them many years to find out if a variant is disease causing in an actual functional study. But what we do, and if you read some of the papers I've published, we really try to interpret the family history to see if there's any other family members that have that variant and also have the same symptoms. And then we try to publish it. So that's why if you have family members who are affected, you have other people, the more people we get who get involved, who actually do the genetic testing, the more information we'll get. And I have a lot of variants just not even for periodic paralysis, but also for hereditary neuropathies, for a lot of hereditary neuromuscular conditions. So the more, that's why I tell patients to go out, see their doctor, to get the help, see the right physicians who are going to take this to the next level.
Okay. Miriam asks, if no myotonia is seen on an EMG, but a person has all the symptoms of myotonia and hypo-KPP-RY-R1, should they even mention their myotonia symptoms?
So I don't know. I can comment, or I feel I should let you go first, Dr. Jerath, if you want to talk about complaint of stiffness, but a normal EMG.
So the question is whether she's had a normal EMG, but she has myotonia. Is that the correct? And she said that she doesn't believe that the other physician thinks she has myotonia because of her EMG. Is that?
There was no myotonia on the EMG.
Correct, but she clinically feels she has myotonia, right?
Right.
So that's what's really hard, and I did bring that up in some of the cases I brought up, that RYR1 in the chart, cases I talk about all over the country. It's not, our EMG testing is operator dependent. It's not 100% perfect all the time. So I do tend to focus on the clinical presentation, even if we don't happen to find a perfect fit with EMG. I would love for it to show myotonia. That would be a perfect scenario, but not every EMG test is perfect, and each individual is different. We've had patients who've had normal EMGs, and then 30 EMGs abnormal. And then you're like, wow, now this patient has a neuropathy, or now this patient has myotonia. So sometimes it's not evident on that first EMG. And these are diagnostic difficulties. They're hard. They require a lot of patience and a lot of tenacity. So the patient should never give up. If she really feels like she's having myotonia and she needs it to be treated, she should tell her doctor.
Well, it's getting close to time to close, and I'm going to reserve the last question for the PPA, both of you. And I would personally like to know if there's something that the PPA can do as an advocacy group to further the work done in periodic paralysis. And I don't necessarily mean financially. I mean, is there anything we can do as far as bringing doctors together to talk and giving them a platform? I'm open to any ideas that you might have.
So I'll start. First of all, I appreciate everything you have done. The awareness has increased phenomenally. I mean, I started with this in 1990 when I had my first opportunity to study a muscle biopsy from a patient. And it's gone from obscurity to, now it's taught in medical school and more people know about it. So your awareness campaign is great. The fact that you provide resources for patients and physicians and the reprints and descriptions is extraordinarily helpful, because to go even as a healthcare professional and do a Medline search or something for periodic paralysis, it can be bewildering. And it comes back to the clinician is a mixture of hardcore basic science papers and clinical papers, and it can just be, oh my gosh, this is overwhelming to sort through. And you have done a fantastic job at queuing all that up and making it very accessible, timely, renewing it as more information becomes available. So that's fantastic. I will just also say, and then I'll let Dr. Jerath speak, that we all are data-driven as scientists and physicians, and I understand the importance of carefully designed surveys and everything, but I can't tell you how much I appreciate coming to the PPA meeting, in particular when it's live, so that I can personally hear the stories, and even more importantly, at the end of a talk like this, I can ask a show of hands, just like we attempted to do. And while the rigor of that might not be high, the value of that feedback is incredible. And I have certainly been educated about things like the pain that comes with myotonia and what triggers an attack. And so bringing people together, having physicians come, I think moving the meeting around to different locations in the country or even internationally. I know mobility is an issue for a lot of people, but that helps bring new people into the fold, I think, by having it be local. So those have all been helpful things.
Thank you. Dr. Jerath?
Yeah, I would agree, and I think that in some way I think we need to get the physicians who are leaders in this field together to move forward and to get information. And this would be leaders outside of the United States. I know Dr. Lehman Horn is no longer here, but I'm sure he has a lab and a legacy that we could connect with. So I think that we would want to connect with those leaders. We also want to connect with the patients. That's a big deal for me because my research is patient-driven. My patients just tell me things that I'm learning from them every single day. And so if they don't tell me, if they don't speak up, if they don't get their genetic, they don't have to get genetic support. If they don't get it, if they don't come, then we're losing out on our knowledge. So that is a really important piece. And so bringing all those patients to come see me or to see the other leaders in the field has been just phenomenal. So really grateful to the Periodic Paralysis Association for that. I think from that next step, we need to create research studies. And that's something in my mind since that initial question about how to redefine the diagnosis came up. I'm thinking, how can our patients help us with this? How do we move forward? I mean, do we do surveys? But they're not scientifically rigorous, right? So that's a huge problem. Do we have to have them come to my clinic, come to see Dr. Cannon? I mean, come together and get all the variants and everything sorted out in terms of the new presentations. So there's a little bit of work that we need to do together behind that to actually move the field forward. I think we're right there, but maybe coming together in some way. This conference was excellent. It's a great first step. But coming up with research ideas that we can do all as a group, it's just natural history is a good beginning more than anything else. So that's my feedback. I'm just so blessed to be part of this and grateful for all the patients that we can help.
Well, thank both of you. You've been wonderful, and we will be seeing you again next year in person, we hope. So I'm going to take presenter back because we have come to the end of the conference, and I just have a couple more words to say. So I'll talk to both of you soon, and I'm just going to change. Bye-bye.
All right, bye. Thank you.
Okay. As soon as my screen comes back here, I just wanted to say a couple of things before we sign off. If I can get it to work. We shall see. My hourglass is going very slow right now. No. Come on. There we go. I seem to just have a slow computer all of a sudden. It's just been wonderful today, and I truly appreciate all of the attendees who have been here listening all day long, and special thanks to all of our doctors who have been with us. I would like to ask all of the attendees who are still here to keep your screen open for a few minutes when the conference ends, because you're going to have a short poll on what you thought about the conference today. Tomorrow, you're also going to be receiving an email from us with a short survey, and we would like you to return that to us, as it will provide us with information for future webinars we will be having throughout the coming year. And that's something that you should all know, is that the Periodic Paralysis Association, now that we have this format for doing webinars, we hope to be doing these on a monthly or bi-monthly basis with various individuals on different topics. It'll be a much shorter webinar, maybe an hour to an hour and a half. We hope that these short webinars will bring you news, and as we receive it, and keep you engaged as members of the PPA, because we need your input now more than ever. And that's really what Dr. Cannon and Dr. Jerath just alluded to. So thank you for attending today. It's been a whirlwind day, and a lot of work went into this. We were scared starting out, but so much information has been given to us, and I just want you all to digest it, reach out to the PPA with questions, and always, always remember that you are not alone. We'll see you soon. Bye-bye.